subjects. They're a little beyond me. You're having to talk to folks that do infertility. There's many reasons why a woman will not ovulate. We do, as generalists, as OBGYNs, we can do some ovulation induction, but not with anything. Most generalists will do Clomid treatment, and I can talk a little bit about how I do that, how you do that, and but beyond clomiphene citrate, that is the realm of the infertility guys, the subspecialist. We're not really necessary in the first trimester. The big to do about prenatal vitamins at this point, and trying to encourage women to take it from the beginning, is the folic acid. And again, I think I did talk about the fact that folic acid decreases the chances of miscarriage, spontaneous pregnancy loss, and also it decreases the chances of neural tube defects and certain neural, genetic abnormalities. Now, like I said, the British are the ones that came up with that, and the magic number for a woman that is not at risk is 700 to 800 micrograms of folic acid, which is what most prenatal vitamins have. Now, there's been some studies talking about increasing that dose to 2 milligrams of folic acid on people that have had either recurrent pregnancy losses in the first trimester or neural tube birth defects. So we'd give them 2 milligrams instead of 1,000 microgram is 1 milligram. So you give them a high dose of folic acid. But now you kind of push them in the first trimester, in the first few weeks of conception, because decreasing that risk. Probably a philosophical than a medical. If you have somebody that's 35 years old and she's trying to conceive and she's gone through 6-7 months of attempted to conceive on her own and it's not succeeding, I think that patient will benefit from a workup much more than a 21-year-old that's gone through the process for a few months. I mean, the 21-year-old, I think you can tell her, listen, just go home and keep trying for a few more months. And you might give them a little advice as far as, go get you an ovulation predictor kit, timing of intercourse, that type of thing. But I don't think that patient that is young and is early in her reproductive life deserves a mega workup, where a 36, 37, 40-year-old that is having difficulty might deserve even referral to infertility for, IUI, intrauterine insemination, or something of that sort, or to measure the amount of follicles. They can do an ultrasound, and based on the ultrasound, determine what her ovarian reserve is, how many follicles they have. So you can give, I see patients that are 42, 43 years old, and they're thinking about conceiving again, and they want to know what their chances are. Well, it's almost impossible to tell them on their own, spontaneous pregnancy. But I tell them, you go down and go see my friends in infertility, and they'll counsel you. They'll do a consult, and they'll do an ultrasound. They'll look at your ovaries and determine how many follicles there are that appear to be viable follicles that are destined to ovulate and generate an embryo if you have intercourse. And then you have an answer. If you have a very poor ovarian reserve, then you have the option of ovarian stimulation or follicle stimulation to recruit those last few follicles and conceive. Or you go down the pathway of in vitro fertilization, which is essentially stimulating the ovaries to generate a follicle and taking it out, putting it in a dish and putting some sperm in there and getting them to generate a zygote or an embryo. But those things, those technologies are very common nowadays, but they're very expensive. So, I've done the clomiphene citrate on people that are wanting to conceive, that are at the tail end of their fertility, just because they cannot afford anything else. Because most of these options are not options that the insurances will pay for. So it's out of pocket, and a significant amount of money. I think a cycle of IVF nowadays is somewhere around $15,000 to $20,000. You're not talking about chump change. Anything else that I need to touch on? Obviously, that has a renal patient. They have a terrible chance of conceiving, and they're the very high risk pregnancies. If you have somebody that is a renal transplant patient, it's a nightmare. The same thing with women that have systemic lupus or any kind of a chronic morbidity like that. They're difficult pregnancies, and you got to counsel the patient at that point that they're putting their life at risk to a certain degree with some of these problems, and they end up with pregnancies that are very short, and you end up with babies that are very premature. But there's that drive to conceive and to procreate can be very, very, very strong, and that's why infertility is a very is a bad thing. I mean, people they're a lot of the largest and biggest crises that I've seen in people's lives are the inability to conceive. I mean, it really can ruin somebody's life, because you sit there and you go, the 16-year-old girl down the street did it without wanting to, and here I am, and I can't do it. So I've seen very significant depressions over it. But you also have to tell the patient, your obligation is to try to counsel the patient. And I believe that you should try not to taint your recommendations with your own personal bias, but sometimes it's hard. And you need to tell the patient, hey, you have a bunch of different chronic diseases, and you should probably not conceive. You had 5 C-sections, and you want to have a 6th baby, and you have bad kidneys and a bad liver. But I've seen that. I've seen where they want to make another baby, they want to conceive again. They're in their 40s, so there's a lot to it. There's a lot of that's where you have to tailor your counseling and your recommendations to the patient. So, what? I'm sorry, ask me again? Yes, it can. There's been several studies that have looked at anxiety, stress, and infertility. And that is mainly been studied in women that can't get pregnant. And the less successful you are at conceiving, the more stressed out you are. And I see it more from I'm a woman's doctor, so I don't see the guy that much. But it can affect infertility or fertility. The anxiety and the stress associated mainly with not being able to conceive. To the point where some of the recommendations are, have a glass of wine, relax. And that's where you see women that say, well, I was trying to have a baby and I couldn't. And then we say, well, whatever happens, happens. And then boom, they're pregnant. Now, how much of an association there is? What is the number? I cannot give you that. But there is an association between anxiety and stress and infertility. Maybe that's why teenagers get pregnant, because they're not really thinking about that. Anything else?
No, I think that's it.
Okay. Well, I'm willing to do this again for you. So you tell